Greetings to my sisters and brothers across Northeast Georgia Presbytery and anyone else who may have occasion to watch this video. My name is Dr. Ed Boland. I'm a family practice doctor working in Augusta, Georgia. I'm a member of Reed Memorial Presbyterian, where I am a ruling elder, and I also serve on the Northeast Georgia Presbytery Committee on Ministry and on their COVID-19 task force. A week or so ago, a local Rotary group asked me to give a presentation on COVID-19. And in this past week, I was asked to repeat that for the Committee on Ministry. They felt there may be some value in sharing this information with those of you who are working, leading our churches, trying to decide what to do about opening in-person worship. So I hope that you find this information somewhat useful. By way of introduction, I am a graduate of the United States Military Academy at West Point. I served as a field artillery officer and then decided to go to medical school. So I was allowed to branch transfer to the Medical Service Corps and work as an environmental engineer. A lot of my work involved industrial hygiene, which included respirator fitness and selection of respiratory protection for industrial situations. Following that, I went to the Medical University of South Carolina in Charleston, graduated and came back into the Army, did a family practice residency. And after 2 years out of residency working in a family practice clinic, I went to the University of Washington to get a master's of public health, and then to Fort Lewis, Washington, where I finished a residency program in preventive medicine and public health. I spent the last 10 years of my Army career essentially as a public health director for various units and installations, retiring out of Fort Gordon. So with that being said, I am technologically challenged, and I'm going to do my best to share my slides with you. All right, this is the SARS-CoV-2, what we've commonly come to call COVID-19. This is the representation that we've all gotten used to seeing in the last several months. And before I get any further, my wife works at Augusta University, and she would be very annoyed if I don't give a shout out to the graduate of Augusta University, their medical illustrations program, who designed this logo that's now been seen worldwide. Go Jaguars. Coronaviruses are not new to us. Every year, there are at least 4 of them that are in circulation causing common colds. And the amazing things about those particular coronaviruses, which coronavirus is a name for a family of viruses, SARS-CoV-2 or COVID-19 is just a member of that family. The amazing thing about these 4 coronaviruses that circulate every year is that they cause mild symptoms. They are relatively infectious, but they're not virulent. That means that they're pretty easily passed from person to person, but they don't cause a great deal of damage, just some discomfort for a few weeks. You may recall the first time that we really used the term SARS very much, which, by the way, stands for Severe Acute Respiratory Syndrome. We had SARS-CoV-1 back in 2002 to 2004. And unlike the coronaviruses that we see spreading around causing common colds, SARS-CoV-1 was actually, it was very virulent in that it caused severe respiratory disease and a lot of death. But thankfully, it wasn't very infectious, meaning it wasn't easily spread from person to person. And so after about 2 years, it just sort of fell off of our radar screen. Back in 2012, you may recall that we had MERS, or Middle Eastern Respiratory Syndrome. MERS was also a coronavirus. And like SARS-1 before it, it caused a lot of damage if you got it, but thankfully it was not easily passed, and so it sort of petered out. Unfortunately, with COVID-19, It is both infectious and virulent. It is fairly easily spread from person to person. And as you've all probably seen on the news, it's causing an awful lot of disease and burden, not just death, which is what we tend to focus on, but there are an awful lot of people that are going to really be sick as a result of having had COVID-19. One of the things that is, I'm afraid, is bad news for us is because this is both infectious and virulent, it is probably going to be circulating in low levels in the human population for years and years and years to come, at least until we have a really good vaccine and we can break the transmission cycle. One of the problems that we have, this is a very infectious disease, and the problem is that 40% of the people that are infected with it have absolutely no idea. They have no symptoms. Unfortunately, they're able to spread it. And how are they spreading it? Well, two ways have really come to light. One is through aerosols. Those are the droplets. I know it sounds disgusting, but every time that we speak, we're spitting on each other. So the little tiny droplets that come out are full of viral particles, and those droplets tend to land on surfaces. We now know that if it's a hard, impermeable surface, that the virus will live for about 3 to 4 days. If it's a soft, absorbent surface, it can last for 1 to 2 days. But those droplets hit the surface, and at some point we come along and touch that surface, and then we wipe our nose, we pick at our eye, we pick at our lip, and we've now infected ourselves. That's the most common way, is through aerosols. Of course, people have the ability, as we're talking, if we're getting too close to them and they're talking and spitting, those droplets can come straight into our respiratory system. There has recently been some discussion about whether or not this disease can be passed through air ducts. And we know now that it actually can, which may have some impact on your willingness to use your air conditioning systems in churches. But that is not as common right now as the droplet transmission chain is. I'd like for you to think about transmission risk for just a minute and think of this as a math problem. Transmission risk is going to be equal to 3 things. The first one is the number of viral particles that you're exposed to. So think of that as the number of little virus particles that are floating around inside that droplet of spit. How many droplets of spit did you just get exposed to? And with that, how large a number of viral particles did you get exposed to? The amount of time that you're exposed. We now have some pretty good studies that show that if you are in an uncovered conversation or have some other exposure where you're not protected and the infected person is not protected, that after about 15 minutes, you've reached your maximal exposure, which says something to those of us going to church for an hour. Critical that we take steps to protect each other at church. The third thing is, what's your immune status? We know that people that have a suppressed immune status, whether they're taking chronic prednisone therapy or whether they have an underlying disease, whether that's a heart disease, a lung disease, kidneys, we now know that anybody with a lowered immune status is at a much higher risk of a bad outcome after a COVID-19 infection. So think of these 3 things as equaling to your transmission risk. This is the current standing as of about 30 minutes ago. I pulled this data off of the Johns Hopkins University COVID-19 Resource Center. Their dashboard I find to be very, very useful, and they update this information constantly. You'll see there that in the United States, we're up to 6.5 million confirmed cases of COVID-19. And we're at 193,000, almost 194,000 deaths. Worldwide, over 28, almost 29 million confirmed cases, and we're pushing almost 1 million confirmed deaths. I suspect that we're much farther along than that, given the number of countries that are not reporting data. Are we doing anything to flatten the curve? Again, this is from the Johns Hopkins site. The United States is the curve that's in orange. And you can see we had a big spike going into July. And then we all started getting a little complacent, going, yay, things are coming back down. But in the last 2 weeks, we've hooked back up. Now it remains to be seen, is this just a little hook and the trend will continue down? Or are we going to start to spike back up? The green line is India, which is blessings and prayers on India, because they are very, very much in danger and struggling right now. One of the things that I really like to hit on, because they help me outline other points, but there have been several memes and postings on Facebook that caught my attention, and I wanted to share them with you. Start with this one. This was posted by one of my patients who noticed that, hey, according to the Centers for Disease Control, this disease has a 1% mortality rate. That means if you look at the entire population, if 100 people get the disease, only one of them will die from it. Like all really good fallacies, there's a little bit of truth in that. The truth is, if you look at the entire population of the United States, all ages, all races, all socioeconomic statuses, this is true, that the mortality rate is 1%. The problem, though, is a little more complicated than that. If you break this down by age group, and let's look up here first if my cursor is showing on the screen for you. You know, deaths in the United States based on age group, if you are under the age of 1 all the way up until you're 34, if you're infected with COVID-19, your risk of dying from it is less than 1%. So hooray, that's great news. The problem starts, as you can see in the red box here, from age 35 on up through 64. Between 54 and 55, your rate starts to jump pretty dramatically, from 4 to almost 12%. Once you hit 65 and older, the rate is going up dramatically. And my goodness, once you hit 85 years of age, if you're 85 and you are exposed or infected with COVID-19, you have a 1 in 3 chance of survival. So while it's true that as a population, we have a 1% mortality rate, the group of people who are probably most likely to attend our churches in person, those folks 55 years and older, have a much, much, much higher mortality rate, a much, much higher risk of death in the event that they were infected. Folks, it's not just about death. There's an awful lot of disease, prolonged disease, that's coming along with infections. For every 1 death from COVID-19, there are going to be 19 folks that are hospitalized, 18 that are going to have permanent heart damage, 10 that are going to have permanent lung damage, and 3 that are going to have a stroke. One of the really, really terrible things about this disease, we thought initially it was just going to be a respiratory disease, and you'd get sick and you'd have trouble breathing, you'd cough, you'd run a fever, but then it would go away. And what we now know is that this disease affects almost every single organ system: kidneys, heart, lungs, pick a brain. So pick an organ system and you can almost guarantee that COVID is going to be finding some kind of damage to do there. This is another Facebook meme that was posted, and it was posted by one of my West Point graduate friends. And again, there's a shred of truth in this thing. They're pointing out that the mask that you need to prevent virus inhalation and absorption is one of these masks. And this is, in all likelihood, an N95 cartridge. So yes, if I'm working in a laboratory or if I'm working in a hospital and I'm afraid that I'm going to be exposed to this virus, the thing that I must do to protect myself to the very best of my ability is to wear a very tight-fitting N95 capable respirator. But what this meme fails to recognize is that, remember from our risk of transmission math problem, that one of the major drivers of your risk of infection is the number of viral particles you're exposed to. So anything that we can do to decrease the number of viral particles is going to work to our advantage. So while they were obviously trying to make a point here that the N95 is not going to protect lab workers or potentially doctors from exposure to COVID-19, that was somehow political science and a mind control device. The truth, again, is a little more complicated. You'll notice from this drawing, a smaller aerosol droplet only has room to carry a single, in this graphic representation, there's only a single viral particle. But the bigger droplet, more viral particles. That makes sense. So let's look for just a second at masks and at particle sizes that they protect against. Here you'll see I've circled surgical mask, what we're currently wearing. Down here is the N95 mask, like we were just talking about. The very top is the size of particles or droplets that these particular devices protect against. And you can see that an N95 mask protects all the way down to less than 0.3 microns. Now, to give you a frame of reference, a red blood cell is about 7 microns. Here you see different kinds of molds and bacteria. They live down in this less than 10 micron range. So an N95 mask would be protective all the way down to less than 0.3. The surgical mask is only protective to about 30. So the interesting thing is, if we're exposed to aerosols that are greater than 30 microns, then this surgical mask should be protective. You'll see here I've drawn this line in blue. The aerosols that we spit on each other range in size from 1,000 microns all the way down to about 5 microns. So from 30 microns on, the particles that are bigger and therefore have a greater chance of carrying more viral particles, our surgical mask is going to do a pretty good job of blocking that. Well, what about these particles coming out in the less than 30 micron range? Well, folks, that's why we stand 6 feet away from each other or farther. Remember, for our singers out there, singing is considered the same as shouting. You project those particles with a lot more force. And so instead of 6 feet away, you need to be 18 feet away. Just as a trivia point for you, if you cough, those droplets are leaving your mouth at about 50 miles per hour. If you sneeze, they're leaving at about 200 miles an hour. Just a fun fact in case any of y'all go in jeopardy. A third Facebook meme for you. Trying to make, and this is an equivalency that was made early on, is flu and COVID-19 somehow close? Is COVID-19 being blown out of proportion for political gain? And again, the facts that are on here were relatively true. Although as a public health officer, I would argue that the response to H1N1 was a lot more vigorous than none, since it ate up the better part of a year of my career. But nonetheless, US cases, 61 million for H1N1. COVID-19 cases, 5 million. What's the big deal? Again, there's a bit of truth in every fallacy. Here's the thing that we're overlooking. Total deaths from H1N1. We're not exactly sure, but they range all the way up to 575,000. That's total deaths from H1N1. But total deaths from COVID-19 are very soon going to be double that worst case number. This was in a year. This is in 7 to 8 months. In the United States, total deaths from H1N1, 12,000, and well, call it 12.5 thousand. In only 8 months, we're already up to 193,000. An order of magnitude worse than H1N1. So yes, while the number of cases seems to be a little bit, what's the right word? The argument looks like it's being skewed towards making COVID-19 worse than it really is. I think if you'll look at these data right here on deaths, we're not making this case, this is not a mountain being made out of a molehill. This is a big deal. And especially in terms of those higher age group folks that are going to be coming to our sanctuaries. There's been some discussion online, are we about to get a super storm of flu combined with COVID? Just for the sake of time, let me say, I think we're going to have probably a very, very good flu season, because how do we prevent flu? Well, we wash our hands and we cover our nose and our mouth when we cough. So by simply doing those things that we're going to be doing for COVID, I think we're going to prevent an awful lot of flu disease this year. For the longest time, we were amazed at how little COVID seemed to be affecting children, and you saw how low their mortality rate is. What an incredible blessing that is. What we now know, though, is that these children are very, very capable of being infected. Most of it is asymptomatic, but they're capable of carrying up to 5 times the viral load in their noses and very, very capable of sharing this disease. So even though not a lot of children are getting sick, going to the hospital, and dying from this disease, they are very, very much a part of the chain of transmission that we all have to be aware of. What's some good news? Well, there was recently an emergency use authorization for the use of convalescent plasma for folks that are in intensive care units. It seems to be improving survival. That's a wonderful thing. Remdesivir. I left this on my slide because when I gave this talk 2 weeks ago, the morning that I gave the slide, news came out that remdesivir had been demonstrated to not be effective. So I leave this on here as a reminder for me to ask you to please be kind with your healthcare providers and your doctors and nurses as we talk about this. Things are changing under our very noses, and what we say today, I think most of us would say we reserve the right to change what we say tomorrow, because we're trying to give you the best information that we have given the information that we're aware of. So remdesivir turned out to not be so effective. The good news is, though, that use of dexamethasone, a steroid, is lowering the burden of respiratory illness. And there's been an awful lot of sharing of research between people who are normally competitors in the race to get us good treatment. And I just find that to be very helpful, very hopeful news. You may have heard of Operation Warp Speed. That is the effort by our government to get a tested and authorized vaccine in production and available to the public, hopefully by November or December of this year. There are currently 7 vaccines that are in human trials. You may have heard that one of them was stopped last week. A lady developed an infection or an inflammation around her spinal cord, and they stopped the disease while they try to figure out whether the vaccine caused that or if there were other issues. That has not stopped the other vaccines in their stage 3 trials. And I am very, very hopeful that we will have a vaccine approved, FDA approved by the end of this year. However, I do want to say, even with the amount of vaccine that we're hoping to have in the first quarter of 2021, that will barely cover the needs of healthcare workers and folks in the highest risk groups based upon age. It will probably, best case, be the third or fourth quarter of 2021, so almost a year from now, before we have sufficient amounts of vaccine to have mass immunization plans or programs. Again, the vaccine doesn't have to be 100% effective. We just need a fairly effective vaccine that provides immunity to about 50% of Americans. That's a tall order. That's a lot of vaccine. So again, be open-minded, read science, talk to your doctors and nurses. As we talk about these vaccines, there's going to be an awful lot of political backlash to that. Really good news. We were worried that COVID-19, being a coronavirus, may be like these coronaviruses that we see every year that give us the colds, where we're not capable of getting sustained immunologic reaction and protection. So if I'm exposed to one of those coronaviruses this year, next year I could be exposed to the same one and get sick all over again. My antibodies are not protective long term. Thankfully, it looks like the COVID-19 survivors are getting some prolonged immunity. Even though it's not necessarily antibody-mediated immunity, they do have a better immune response than others. And so that's hopeful for those folks that are making vaccines and trying to come up with therapies. Doctors are protesting and no one knows why. Well, we're protesting because we can't understand how any of this got to be political. The science changes from day to day, and I know that's confusing for folks, but please, please get your information from a legitimate source and not Facebook. Thank you so much for the opportunity to share with you what I have learned about COVID-19. If I can be of use to your sessions or your congregations, I'd be happy to do as much as I can. This is my email address. My Facebook page, or I'm sorry, my website is drboland.org, and my email address you see on the screen, drboland@drboland.org. Blessings to you and all your congregations, safe health, and wise choices.